Good day, everyone, and welcome to today's United States of Care Legislator Learning Collaborative about state Medicaid innovation. At this time, all participants are in a listen-only mode. Later, you will have the opportunity to ask questions during the question and answer session. You may register to ask a question at any time by pressing the star and 1 on your touch-tone phone. Please note this call may be recorded. I will be standing by if you should need any assistance. It is now my pleasure to turn the conference over to Ms. Joanna Dornfeld. Please go ahead.
Hello. Thank you for joining us today for United States of Care's first Legislator Learning Collaborative about state Medicaid innovations. I'm Joanna Dornfeld, and I'm Senior Director for State Affairs with United States of Care. This morning, I'm going to provide a quick explanation of United States of Care for those we may not have had the opportunity to meet, describe our most recent initiative, the launch of our Legislator Learning Collaborative, which we're doing today, and introduce our experts for today, Jason Helgerson and John McCarthy, our fellows, before turning it over to them for the main event. We'll have time at the end to answer questions about any portion of today's webinar. First, just a little bit about United States of Care. We are a nonprofit that was formed about 18 months ago by a diverse founders council who came together around our mission that every person in America should have access to health care they can afford, no matter their health status, social need, or income. We are a nonpartisan nonprofit that believes that by working with diverse stakeholders from all across the country, we can make progress toward achieving our mission. In addition, our theory of change is that states are where there is the greatest opportunity for change. We are actively engaged in work in more than a half dozen states and seeking partnership opportunities and others to continue to work toward our mission that every person have health care that they can afford. United States of Care is guided by our core principles that everyone should have an affordable, regular source of care for themselves and their families, that all people and families should be protected from financial devastation because of illness or injury. Policies to achieve these aims must be fiscally responsible and win the political support needed to ensure long-term stability. As I mentioned, United States of Care was founded by a very diverse founders council, and it is one of the things that makes us unique because we're able to draw on the expertise not only of our fellows, Jason Helgerson and John McCarthy, but as well as our Founders Council members who serve as informal advisors, offering diverse expertise, experience, and perspective to inform our work. Now a little bit about our Legislator Learning Collaborative. This is the first of what we envision will be quarterly webinars that will provide an opportunity for legislators from across the country to network with each other, learn from, and discuss important healthcare topics. In addition, it will provide access to United States of Care extensive expert network. And lastly, that we envision that these quarterly webinars will be on topical healthcare issues with additional opportunities for information sharing and collaboration. Some of the future topics that we anticipate having webinars and other learning opportunities about include navigating health and human services budget constraints, rising prescription drug prices, mental health parity and access to mental health care and addiction services, addressing provider shortages through telehealth and scope of practice policy, promoting economic mobility and self-sufficiency, and challenges and solutions that are unique to rural America. We welcome your suggestions and feedback today about today's webinar and suggestions for future topics as we hope to continue to grow this collaborative learning opportunity. Now it is my pleasure to introduce you to our two presenters. Jason Helgerson and John McCarthy are United States of Care Fellows and also have an incredible depth of expertise and experience in Medicaid. Jason is an entrepreneur, investor, and consultant and social change agent. He founded the Helgerson Solutions Group. He also advises private equity firms and venture capital funds, as well as works as senior advisor to McKinsey & Company. He is also the former New York Medicaid director, where he served for more than 7 years, while also serving as the executive director for New York's Medicaid redesign team. In addition, he served as Medicaid director for the state of Wisconsin and was a principal project sponsor for Badger Care Plus. John McCarthy has more than 20 years of healthcare consulting and government leadership experience. He is a founding partner at Spear Healthcare Strategies. He works with clients across the industry to help them respond to policy and legislative changes and make sound business decisions. John is the former Medicaid Director of Ohio, where he served for 6 years, as well as serving for 5 years as the Medicaid and Policy Director for the District of Columbia. It is my pleasure to turn it over to Jason to kick us off.
Great. Well, thank you very much. It's certainly a pleasure to be speaking with all of you. Obviously, Medicaid is an important topic for state leaders, including legislators. It's often either the largest or the second largest line item in the budget for any state, and so often generates a lot of discussion both inside and outside the budget process. So I know John and I are excited to have this opportunity to talk about some of the things that states can do to innovate in this obviously very important government program. So just a couple of opening thoughts. I think it's first and foremost important to think about Medicaid across the country, in the sense that there's a saying in Medicaid that when you know one state Medicaid program, you know one state Medicaid program, and that they all differ, and that while it's a federal entitlement program, it just really is state administered, and over time, over decades, each state's program has evolved. And so not all good ideas work in all states. And so depending on which state you're in, you need to understand the political environment, the culture, the history of that state as you think about what ideas will work in that state context. Also, it's important to think about Medicaid in the sense, and oftentimes when we get into budget discussions, big, new, interesting ideas often require new funds. And I think that sometimes leads to an underappreciation of the fact that Medicaid is a big, complex program with lots of subparts, and not all those parts are working. And if you actually can look to fix those parts, you can actually get better outcomes and lower costs. I think there's tremendous opportunities for win-wins that don't involve tremendous new expenditures. Also, in terms of bringing ideas, particularly those of you who are advocates looking for change in your state, be specific. Oftentimes, and I know John and I have had this personal experience of advocates coming forward with ideas, or actually in more cases, they come with problems without really any ideas and solutions to how to address those problems. I think that the advocates who are the most effective are the ones who actually take the time to develop a proposal that's pretty specific, and bringing together a group of organizations in support of that very specific solution to a very specific problem. So specificity is important. And then lastly here, in terms of these opening thoughts, I think it's important to realize that Medicaid is big and complex, and sometimes the challenges that vex the program are often hard to fix legislatively. And at some point, you need to sort of trust the agency. Now, I'm all for legislative accountability and hearings and timelines and public reporting requirements, but I do think that it's oftentimes difficult to solve some of the more complex challenges simply by passing a bill and such. So we want to go to the next slide. We'll start with our list of interventions. We identified 4 things to talk today. Obviously, there's lots more there that you could go into, but we've sort of picked 4 topics that are pretty hot these days and being discussed quite a bit around the country. First is social determinants of health. It's hard for me to go anywhere without people asking about it, talking about it. So we'll chat a little bit about what states are doing in some pretty innovative ways. Next is the other really hot topic is value-based payment and the move away from fee-for-service reimbursement to a great extent national Medicaid program or state Medicaid programs are really leading the nation in this area. And so there's a lot of things that states can do, not only to drive the Medicaid program, but all providers and payers in their communities into value-based arrangements and get out of the cycle of fee-for-service. Then next, 2 very specific things that look at subsets of the population. First is First 1,000 Days Initiative. So Medicaid really has an outsized role relative to young children. Roughly about 50% of kids who are born in this country are born while their parents are on Medicaid. And many young children remain on Medicaid or touch the Medicaid program during their first 1,000 days of life. So some states are doing some interesting things in that area. And then lastly, we'll finish with justice involved in individuals. A lot of people cycling out of the criminal justice system back into the Medicaid program. And we have traditionally not done a very good job of connecting those people to services. There's a great opportunity to reduce recidivism in prisons, and particularly John will talk to that today as well. So first off, let's start with the social determinants of health. If you want to skip a couple slides ahead, if you don't mind. Someone will, thank you. So first off, social determinants of health, and in my time as a Medicaid director, I've seen a great evolution in thinking around this, from it being very much the minority view that it was the responsibility of healthcare providers, or particularly the Medicaid program, to address things like the social determinants of health, to it really being a majority, in fact, super majority position. It's hard to find people who don't acknowledge that in some way, shape, or form, the health system has to address the social determinants, and people define it in somewhat different ways, but you can sort of define it as they're determinants of healthcare conditions, which are really based on the environments in which people are born, live, learn, work, play, worship, and age. And these are things that are not oftentimes trump the healthcare need of the individual and directly affect their ability to function, their quality of life, as well as the risk of need for really expensive healthcare services. Some of the very specific examples are housing, food, clothing, education, and community. Next slide. So one idea that wanted to put out there in terms of what states could do to drive forward is that while SDOH has been talked about, it's often still to this day a sideshow, even within the Medicaid program. And many Medicaid sort of has a disproportionate share of individuals who have SDOH needs. And so one area that states could move forward with, whether this is part of a Medicaid managed care RFP, and it's important to point out that well over 40 states use some amount of Medicaid managed care. Most of those do RFPs. But even if you're not an RFP state, modifying your Medicaid managed care contracts to begin to put in specific sort of minimum effort requirements for managed care organizations to begin to address those needs. While I think many of us have thought intuitively that it would be in the interest of plans to launch these efforts, I think they have oftentimes been sort of conservative with a small c relative to these things, not knowing exactly what the ROI could be. And I think the states could go even one step further than simply sort of general statements around this, and really begin to require that their Medicaid managed care plans, who are really their stewards of the program out there in the field, to actually submit annual plans to the state, and as part of that, commit a % of the total premium, total revenue that's coming from the state to addressing the SDOH needs. And also encourage, as part of that, would be to utilize community-based organizations that are oftentimes culturally, linguistically competent in communities in that state, to use those as their partners for addressing those needs. You could also look as part of the managed care RFPs to give additional points to plans that commit to such efforts. So I think there's a lot you can do in this. It doesn't require an increased expenditure that really could up the game. With billions of dollars moving through Medicaid managed care, we think this is a great opportunity to address SDOH without a new line item in the budget. So I'll turn it over to John to talk about what they're doing down in North Carolina.
So North Carolina recently had an 1115 waiver approved, and this is a groundbreaking waiver where CMS is letting them spend $650 million on social determinant of health pilot programs. And of that $650 million, about $100 million can be used on just infrastructure, building that. And speaking of infrastructure, they are using something called NC Care 360. It's actually a statewide resource and referral platform where a company's coming in and they're providing the backbone to be able to connect providers, case managers, managed care plans via the internet to community-based organizations who are actually providing the services. That's not something that's out there right now. This is innovative there. The other innovation there is the Medicaid department is saying that all the health plans must use this one platform to make those connections. The other interesting thing about that platform is that it's a little bit a way of kind of a shopping type of website, in that or a bidding type website where the person is identified and their need is posted to the platform, and then all the CBOs, community-based organizations, can see that person, their needs, and then they go out and pick that person. It then gets tracked to make sure that the person gets their services, and those CBOs then are rated higher for services later on. Now, one of the other things about this is that not everyone in North Carolina is going to be able to participate in the pilot program. It's for people on Medicaid, so you have to be enrolled in Medicaid, managed care. You also have to have some needs. There's some needs-based criteria, and you can see on the slide a couple of different ones that you have. Those are examples. It's not just only those adults or those pregnant women. These are just kind of some examples there, but you have to fit in one of those. And the third thing is you have to have at least one social risk factor in this. And so this is where the state is starting, and as a person is identified, then they would be put in the NC Care 360 system and start getting their services. And here's just a few examples of services offered on the next slide. It's around housing, food, transportation, and interpersonal violence, toxic stress. Those are the services that, often what we'd hear from people is what they would be needing, and often are in some way, shape, or form can help improve their outcomes. So with that, I'll turn it over to Jason to talk a little bit about New York.
Thanks, John. So in terms of New York launched into both a sort of a two-prong effort. First was to do delivery system reform through an 1115 waiver, and then second was a pretty aggressive move into value-based payment. In fact, the goal is by the end of the decade is that 80% of all provider payments through its Medicaid managed care plans would be value-based by the end of the decade, which is fast approaching. And now there are almost 2/3 of payments currently today are value-based, so they're making tremendous progress towards that. But a couple of things specifically within that effort that address the social determinants of health is, first off, the agency actually created a bureau specifically focused on SDOH efforts. And that was exceptionally well received, particularly by organizations that advocated for greater focus in this area. It's led to some really creative, innovative ideas, and it's certainly one thing that almost any state could do in this area. Next was, as it moves into these value-based arrangements, is to require the more advanced ones to include in their contracts not only a commitment to address at least one specific SDOH need of a target population, but also to contract with a community-based organization. So in the case of New York, any what's called level 2 or higher arrangement, which is where the provider's taking on upside and downside risk, that those contracts would include a community-based organization as a partner, and they would be addressing very specific SDOH needs. So once again, another example of how you can push towards addressing the SDOH needs of the population without actually having to spend new money. Just a couple of specific examples. Housing is Health, a regional health plan in the middle part of the state of New York, has launched a specific housing initiative, providing housing interventions for those with multiple chronic illnesses. And included within this is rental subsidies. I think it's important to point out that there's a growing acknowledgement that housing for medically complex, socially complex patients is often the number one factor in their lives, influencing not only their health but their well-being. And you have to figure out a way to address that. And here's an example of a health plan that's doing that in New York State. United Healthcare has been doing this nationally, so that's an interesting place to look. And then breathe better. Bronx, major challenge in the Bronx relative to particularly like asthma and other types of issues. And in the case of this program, community health workers are delivering in-home assessments, interventions, addressing the triggers for things like childhood asthma attacks. And so just a couple of examples there of what's happening in New York to address the SDOH needs of the population. Next slide. So now let's talk about value-based payments, another buzzword that's going around not just Medicaid, but healthcare in general in the United States. And so one thing that I think almost any state should do relative to VBP is actually develop a roadmap for how the Medicaid program in the state is going to implement a value-based payment approach. Medicaid is often the largest or second largest payer in any state, and as a result, if it's unwilling to commit itself to the move to value-based payment, that'll often make it more difficult for other payers, whether that's Medicare or commercial insurers in that community, to be able to move in that direction. I think it's a great opportunity for Medicaid to play a leadership role in what is now becoming a national movement to get out of the traditional fee-for-service system, which is really built in a lot of inefficiency and led to a lot of bad outcomes in American healthcare, to really be a leader in moving away from that system. And while it's coming along, it's not as quick as possible, and I think all payers across the country need to think about what they can do to drive it. In the case of New York, as an example, as part of our 1115 waiver, we have an agreement where we had to develop a roadmap, and it's approved, in fact, it's updated every year and approved by CMS. It's a very, very powerful document for driving value-based payment across the state. As I mentioned, nearly 2/3 of all provider reimbursement already value-based. That would not have happened if it weren't for this governing document. Also, it's important to coordinate with other payers, and particularly Medicare. Some really positive announcements out of CMS in the last couple of days about success of some of their alternative payment mechanisms and models. So you definitely want to coordinate to minimize the complexity for providers. But I do think this is an area where legislators can lead. You can expect the agency to come forward with plans, give them timelines, hold hearings to discuss it. But there's a lot that the state can do through what is oftentimes the largest purchaser of healthcare services in the state. Next slide. So just a couple of other additional approaches, and just in terms of structure. States are looking at VBP in different ways. In some cases, they're being very deliberate, meaning that they're designing alternative payment models and requiring all providers to use those very specific models. Other option is to be a little bit more flexible about using your Medicaid managed care plan contracts as the vehicle for driving. There's also this middle ground, which is sort of the middle ground that New York takes, which is they offer a menu of approved choices. So you give some flexibility, while other states, mentioning one I think off the top of my head, Tennessee, who's been a bit more prescriptive with the specific models that can be used. But there's a lot to learn in terms of which of these approaches will work. But this is, I think, a great opportunity for Medicaid to once again be an incubator for new ideas and practices that not only can then move across the country to other Medicaid programs, but could be adopted by commercial payers and others. So in terms of the New York examples here, in terms of success, as I mentioned, significant progress thanks to its 1115 waiver DSRIP, Delivery System Reform Incentive Payment Program, and the 80% requirement I'd mentioned. Nearly 65% of all those payments providers, and that cuts across all populations and services that are in managed care, representing 90+% of the program population. And the state's approach has been a menu of choices that was approved by the state and CMS. And I think one of the key things about New York is that value-based payment roadmap is updated every year. The idea being that this is still very much a learning process. We're all learning as we make that journey to value. And so we need to make sure we don't lock ourselves into models that ultimately prove to be less efficient than new ideas that come down the line. So I'll turn it back over to John to talk about Ohio.
So on slide 23, we have some examples of value-based purchasing in Ohio. As Jason talked about on the other slide, there's a couple of different models you can use. Ohio did choose to use the model where it was very specific in how VBP would be used. The VBP programs that we centered on were patient-centered medical homes and episodic payments. The patient-centered medical homes is named Ohio CPC, and then episodic payments, if we're wondering what those are, they're kind of like bundled payments, except they're retroactive. You're not giving a provider a bundle of money and then they're just dealing with it. They're operating like normal, then you go back retroactively and take a look at what has been done and do they meet certain requirements, and then from there you would do negative and positive reinforcement. So Ohio CPC launched in January of 2017, and it's includes about 1.25 million members statewide. So it's about 40% of the state Medicaid population. So to put in perspective, much smaller than New York is, but it's still about 3 million people are in the Ohio Medicaid program. So there's quite a bit of members involved in Ohio CPC. And then the Episodes program was launched in 2015. It includes over 43 different episodes of reporting, and there's 18 that are linked to payment, and it's covering about 1.5 million members. So just about half of the members are in there. So one of the reasons the state decided to say we're going to move just with these two models was looking at some other states who had done it through managed care, and what you heard often was through a managed care contract, each managed care plan might be doing something different, so it's hard to get real scale on some of those different pieces. There's ways, and Jason talked about that you could address those. This was more of, okay, we're going to stick to these specific models, try to keep provider abrasion fairly low to have them join the program. It wasn't mandatory for the CPC program, so let's see if we can get them to join. So with that, on to slide 24. These are some of the successes in Ohio. They recently released a report on this. The biggest thing that we heard quite a bit was, well, quality, it's not going to improve. Well, that's not the case. Quality overall through both of the programs increased by 2.1%, and across the two programs, you did have savings. Depending on how you measure it from the report, it's about $121 to $181 million in savings. So that is significant for the state. The Ohio CPC program, what you see there, which was very interesting, the second bullet was, there was actually a negative 1.9% cost trend compared with the non-CPC control group, which had gone up in those cases. So that resulted in about $78 million in annual savings for the program. More importantly, 95% of the practices met all program requirements, including exceeding quality and efficiency thresholds. So when incentivized, you always hear about Medicaid providers and you hear negative stories. I would argue Medicaid providers are some very good providers. Just the incentives often aren't there. And often in the fee-for-service Medicaid program, the incentives are to maybe not do the best thing. But when you put in a program that actually rewards them, you see that you get good outcomes from that. On the episodes program, you see there that efficiency and performance metrics have increased across all the episodes. But again, the savings that the state saw were somewhere between $31 and $92 million in there. And you have a number of principal accountable providers being involved in the program, and they actually received about $4 million in additional payments because of their participation and the quality improvement that they saw. So big successes there. So now Jason's going to talk about the First 1,000 Days initiative.
Great, thanks, John. So First 1,000 Days, as I mentioned earlier, that the first 1,000 days of life are an important period, not only for the Medicaid program, but for the individuals, the children, the families. 85% of brain development occurs within the first 3 years of life. And since these children are this young, it's not yet the responsibility of, say, the K-12 educational system to help be responsible for their successful development. And really, there isn't a single system that's really responsible for ensuring good outcomes during that really vital period of any child's life. So as part of that, New York State launched an initiative that was designed to bring together in very much a cross-sector way leaders from across the state to think about what could the Medicaid program do through its various levers to try to improve outcomes for those children. To give you a statistic, and this is pretty much true nationally, that roughly 40% of children enter the public education system in this country, either at 4-year-old kindergarten or 5-year-old kindergarten. 40% are developmentally behind where they need to be or should be. And that really is a major national challenge, and I think it should call on all of us to do everything we can to increase that percentage. Any child who is not kindergarten ready, as they sometimes refer to it, are much less likely to graduate from high school, much less likely to go on to higher education, much less likely to be successful in life. And so the question we asked as part of First 1,000 Days was, what could we do using the Medicaid program to drive to better outcomes, particularly in that area? It was a major task force that was brought together with cross-sector leadership from the state education agency, even our university system. We brought together experts in the field, people who advocate in the early childhood development space, to come together around a positive agenda to see what can we do to move the needle forward. And also what was key about this was that we set a timeline for ourselves. We knew that processes and task forces can often drag on for a long time, but we gave ourselves a very short window to engage these stakeholders to develop what we said was going to be a 10-point agenda for improving outcomes. And so that all led to a pretty successful process and a series of recommendations that ultimately were approved by the legislature and now are either been implemented or being implemented. And as I said, we knew there was lots and lots of ideas and that would come through the process. We really wanted to get this diverse stakeholder group, almost 40 individuals who are on the main stakeholder group, many more participating in subcommittees, to get those individuals to basically, we had a voting process to get them to narrow down on 10 things the state would do to improve outcomes. And the ultimate list of recommendations was a host of things, ranging from more home visiting to paying for peer family navigators, implementing expand a very effective early literacy program, and a variety of other things that are now in the midst of being implemented. And I think this initiative is less about the specific proposals that New York focused on, but more about the process of engaging across all these systems and sectors and trying to galvanize them into a sense of collective responsibility for improving outcomes in an area where there's no single system, whether it's the K-12 system or the healthcare system or the juvenile justice system. None of those systems ultimately have singular responsibility for this. And I think that's the key reason why we don't get the accountability, we don't get the outcomes we want, if there's no sort of one place to go to say, hey, what are you doing to achieve this? And especially when it's as important as it is to overall society, we definitely think it's an example of where Medicaid can serve as a leader, as a convener to bring together efforts from across the state. So with that, I'm going to turn over to John to talk about justice-involved individuals.
So this is one area that a number of states are taking big strides in this, in providing services to people. I want to clear up a couple things around this area. One is that individuals who are incarcerated and meet eligibility criteria can enroll or remain enrolled in Medicaid. You often hear of like, oh, when a person's in prison, they have to be disenrolled. That is not true. What the federal law actually says is that the states can't claim federal match when a person is incarcerated. There's one small exception, and that's if they leave the prison or jail to go for an inpatient hospital stay, you can claim Medicaid match for those services. But when they are incarcerated, you can't claim for the federal match. So some states have implemented that by disenrolling the person. Of course, the issue then is when the person leaves, you have to re-enroll them, and especially for individuals that are in short stays, that's a lot of re-enrolling and coming in and out of the program. So some states have changed things there. The other thing is states have realized that a large number of people being released qualified for Medicaid, and they have multiple chronic conditions, whether it be health conditions, behavioral health issues, or substance abuse. All those different issues are popping up. And so states that, especially states who expanded the Medicaid program, we're seeing that these individuals were coming out, being released, and how are they to get them engaged into services? So in the next slide, states started a couple different things. Because of the ACA, many states got new eligibility systems. I know, so just so you understand, in Ohio, our eligibility system when I first got there was over 25 years old, and so it was not good at doing suspensions of eligibility. But with the new eligibility system, we're able to suspend people while they were incarcerated, and it was easier to turn that on and off. So a number of states started doing that for individuals. The other thing is that some states began to do enrollment and case management before the person was released, and that's from 60 to 90 days in there. And I'll just give you an example that I know best, which is in Ohio, but Arizona does this. Maryland also has a program like this. But in Ohio, what we began to do was have the person enroll in Medicaid, and we were only dealing with prisons at the time. We weren't dealing with jails. So these were people being released. They were there for a long period of time. And what was interesting is we started working with navigators because you can't force the person to enroll, they have to choose to enroll. We started working with navigators, and the prison system actually said, you know what, it would be better if they actually talked to other inmates in the prison about this. So we educated other inmates to be the navigators to help the person decide if they should enroll in Medicaid and then what health plan to choose. That was a great program because they really were speaking to the person one-to-one. The other thing was that we put a requirement with our managed care plans that they would meet with the person via webinar over the internet so that the person could meet their case manager before they were released. That was really important to make that connection because then when the person was released to their city, the case manager was somebody that they could go to and talk to, and they would be able to get all of their appointments set up and all of their medications ready to go when they were released. One of the reasons I actually did this was because in one of our budgets it was proposed to start providing people 90 days supply of medication. And of course, that's all state dollars when the person's leaving prison. And I said, well, wait a second, let's see if we can enroll some of them in Medicaid and move forward on that. So on to the next slide. As I said, in Ohio, there's the success that we saw there of what was going on. But again, other states have done this too. Connecticut has some great use of services around this. For individuals who are enrolled in Medicaid prior to release, connected to outpatient or more they get outpatient care more quickly than those that were not pre-enrolled. So again, many of these individuals have chronic conditions, so it's really important that when they come out that they can get those services that are needed. Massachusetts, of those that had Medicaid coverage in the year after they were released, 84% used a covered service, including nearly half, 47%, who had a behavioral health visit. The behavioral health visits, both the mental health and the substance use, that's often the reason the person's in prison. So tying the people to those services when they leave, it just really helps. In Ohio, they're still doing some studies around recidivism and seeing if the person who uses services, recidivism rates go down. So with that, we will go to questions and answers.
At this time, if you would like to ask a question, please press the star and 1 on your touch-tone phone. You may withdraw your question at any time by pressing the pound key. Once again, to ask a question, please press the star and 1 on your touch-tone phone. We will pause for a moment to allow questions to queue. And it appears we have no current questions at this time.
Thank you, Isis. And thank you to those who joined us today for participating in our inaugural Legislative Learning Collaborative webinar. I know we really appreciate Jason Helgerson and John McCarthy, their time today to talk to us about some of the interesting and innovative things states are doing to improve care through the Medicaid program in their states. Thanks again for joining us. We welcome your feedback on our webinar today and look forward to you joining us for our next event that we'll be scheduling in the fourth quarter. So stay tuned for additional details about that. In the meantime, please don't hesitate to reach out to United States of Care if there's any way we can support your work related to Medicaid or other healthcare initiatives that you are thinking about for the upcoming 2020 legislative sessions. With that, thanks.
Pardon the interruption. It does look like we do have a question from William Petit with Connecticut Senate. Your line is open.
Hi, I'm wondering if they could make a comment about the people that are incarcerated and how to pay for hepatitis C therapy.
Yeah, so this is John. You actually, through Medicaid, can't pay for the hepatitis C therapy under the current rules of the program because those are being given via a pill, right? So you're not going to an inpatient stay. So there's no current way for Medicaid to do it while the person's in prison. However, if the person's in jail, let's say, and they're just going there on weekends or short stays and then being released to home, you could cover that medicine when they're in there at home. Again, you can't cover it while the person's incarcerated in the institution.
Okay, so no one's figured out how to wiggle around that dilemma, given the cost of it.
That's a pretty tight one there.
All right, I appreciate it. Thank you.
It appears we have no further questions. I'll turn the call back over to our presenters for closing remarks.
Jason or John, is there anything you would like to add?
This is John. The one thing I would like to add, I just want to reiterate what Jason said. There are a lot of good ideas going on there in many different states, and states are working through a lot of different issues. What's really helpful in these situations, if you got an idea, is meet with the Medicaid director, describe what the issue is, and see if there's a solution out there. The National Association of Medicaid Directors is a great resource for Medicaid directors. Jason and I both belong to the organization. We're both board members. I was vice president of the association, and it's a great way for states to share information. Medicaid directors are very open and will talk to one another and give each other what really works and what doesn't work. So if you're talking to your Medicaid director about an idea, that's always a way for them to go get some additional information. Besides that, Jason and I are always working through US of Care. If you ever have other questions or issues around Medicaid, not just these, please feel free to contact US of Care and set up a time to talk to either one of us, and we can go through some of the issues that are out there and what we've seen in other states.
Well, thank you again for joining us today in this discussion about state Medicaid innovation. We look forward to reconnecting with folks, as I mentioned, in the fourth quarter, but certainly don't hesitate to reach out to United States of Care in the meantime if there's any way we can be helpful to you, particularly related to Medicaid or to other health and healthcare issues that you are thinking about in your state. With that, thanks again and have a great day.